Welcome back to Humans versus Machines, the medicine debate, the podcast where we explore how technology and tradition are colliding, collaborating, and reshaping the practice of medicine. I'm Dr. Emily Park, psychiatrist, educator, and your moderator for today's episode, a conversation that brings us into the most emotionally charged moment in medicine: delivering bad news. We've all been there: the scan that changed everything, the diagnosis no one wanted to hear, the silent pause before a word like cancer, unrecoverable, or terminal breaks the air. For centuries, this task has belonged squarely to the physician, a human being, sitting across from another human being, navigating grief, denial, fear, and hope. But in the era of AI, a new question is emerging. Can artificially intelligent avatars deliver serious, even life-altering news to patients in a way that's just as, if not more, effective than we can? Proponents say yes. They argue that AI avatars, when designed with emotional responsiveness, tone modulation, and carefully scripted language, can deliver difficult news with precision, consistency, and without the fear, awkwardness, or variability that many clinicians still struggle with. Critics, however, call this not only ethically fraught, but deeply inhumane. They argue that breaking bad news isn't just about what is said, it's about who says it. That presence, empathy, and the willingness to sit with another's pain is not something you can simulate. So today we ask, should emotionally responsive AI avatars be used to deliver serious or life-altering news to patients? Or is that moment too sacred to outsource? Arguing in favor of AI in this context, we welcome back Dr. Lina Zhang, a Stanford-trained radiologist, machine learning researcher, and staunch advocate for AI's role in streamlining emotionally and cognitively demanding tasks in medicine. Dr. Zhang believes that AI avatars can reduce harm, standardize difficult conversations, and even support doctors who are already stretched thin by the emotional weight of clinical work. She sees this as a tool to empower, not erase, the human role in care. Arguing against the use of AI avatars in breaking bad news is Dr. Emily Carter, a practicing psychiatrist and humanist thinker from Seattle who specializes in trauma-informed care, physician-patient communication, and mental health ethics. Dr. Carter contends that no matter how refined an avatar may be, true empathy cannot be programmed. That bad news deserves more than perfect scripting. It demands human presence, relational context, and the emotional vulnerability of a fellow human being. Together, they'll face off across 3 core rounds of debate: the quality of communication and patient experience, the emotional labor of physicians and how AI may help or hinder, the ethical and trust implications of delegating these moments to a machine. We'll also close with a lightning round, powerful final statements, and a chance for you to weigh in, should your diagnosis or your loved ones ever come from an avatar. Please remember to subscribe, like, and comment on the podcast from wherever you are accessing it. So settle in. This episode will challenge assumptions, not just about what AI can do, but what it should do, and what it means to be human when the news is at its worst. Let the debate begin. Let's begin with opening statements. Each debater will have 4 minutes to present their position. First, we'll hear from Dr. Lina Zhang, who supports the use of emotionally intelligent AI avatars in delivering serious clinical news.
Thank you, Dr. Park. I want to start with something difficult, something honest. Many doctors dread delivering bad news, and too often patients feel the weight of that discomfort. We flinch, we rush, we stumble, or we default to vague euphemisms: mass, lesion, advanced stage, hoping the patient will somehow infer the truth without us having to say it outright. But patients deserve clarity, they deserve emotional safety, and they deserve to hear hard truths from someone or something that can communicate with composure, precision, and compassion. That's where AI avatars come in. We're not talking about cold robotic monotones. Today's emotionally responsive avatars can modulate voice tone, mimic facial expressions, and respond to patient cues with astonishing emotional fluency. These tools are designed with therapeutic communication models, pulling from years of data on what helps patients feel heard, respected, and safe, even in moments of despair. Studies out of MIT and Stanford have shown that patients often open up more freely to virtual agents than to humans when discussing sensitive topics like grief, trauma, or end-of-life fears. Why? Because avatars don't judge, they don't rush, and they don't get emotionally overwhelmed. An avatar delivering a terminal diagnosis doesn't look away. It doesn't tear up. It doesn't send subtle nonverbal signals of fear or avoidance. It stays present, calm, consistent. And here's the key. AI doesn't need to work alone. The avatar can be accompanied by the human clinician, guiding the conversation or stepping in afterward. We're not replacing doctors. We're supporting them in the hardest part of their job. This isn't about cold efficiency. It's about standardizing humanity, giving every patient the same access to calm, clear, and emotionally intelligent communication, regardless of geography, specialty, or clinician comfort. Of course, we need ethical oversight. We need patient consent. But with safeguards in place, AI avatars can reduce trauma, ease emotional labor, and, yes, deliver bad news with more grace than many of us can manage on our hardest days. The question isn't whether machines can feel. The question is, can they communicate in ways that help us feel safe, supported, and seen? And in that regard, I believe the answer is yes.
Thank you, Dr. Zhang. Now we'll hear the opening statement from Dr. Emily Carter, who argues against the use of AI avatars for delivering serious news.
There are few moments in medicine more sacred, more intimate, than telling a patient their life has changed. A terminal diagnosis, a miscarriage, the death of a loved one. These aren't just informational exchanges, they're emotional reckonings, and they demand more than emotional fluency, they demand emotional presence. I've sat with patients after telling them their cancer was back. I've held their hand, not because I was trained to, but because in that moment, words weren't enough. And that's the first danger of AI. It confuses empathy modeling with true empathy. A synthetic smile, a warm tone, a programmed script, it might simulate care, but it doesn't feel. Patients are intuitive. They know when something's real. They read between the lines. They react not just to what we say, but how we hesitate, how our voice trembles, how we stay in the room even when there's nothing left to say. When we delegate that to a machine, we strip the moment of humanity. We turn vulnerability into interface. And in doing so, we risk depersonalizing one of the most human acts in all of medicine. We also risk harm. What happens when an AI avatar misinterprets a patient's question? When it can't adjust for cultural nuance? When it doesn't recognize that a patient is dissociating or too shocked to respond? You can't write a script for grief, and no matter how advanced the AI, it will never hold space like a human can. And what of the clinician? Yes, breaking bad news is hard, but it's also part of our moral contract. It deepens empathy. It keeps us connected. Offloading that labor may ease discomfort, but it also risks eroding the emotional accountability that defines our profession. This isn't just about how we deliver bad news. It's about who we believe should be there when the bottom drops out of someone's world. My answer is simple. A machine may speak, but only a human can truly be present.
Thank you, Dr. Carter. Two very different visions. One focused on emotional consistency through design, the other rooted in emotional authenticity through presence. Up next, we explore what patients actually experience when receiving serious news, and whether AI can truly meet them with the clarity, compassion, and context they need. Welcome back. In this first round, we're focusing on the communication experience itself. When AI avatars deliver bad news, do patients feel informed or abandoned, understood, or emotionally disconnected? Can artificial empathy truly stand in for human presence? Or does the quality of communication and the perception of care suffer when a machine is in the room? Dr. Zhang, let's begin with you. What does the research say about how patients respond to AI avatars in emotionally sensitive conversations?
Thank you, Emily. We actually have several compelling studies that give us insight into this. One notable trial from the MIT Media Lab evaluated emotionally responsive virtual agents interacting with patients during simulated grief counseling. The results: participants rated the avatars as more emotionally stable, less judgmental, and sometimes even more comforting than human interviewers, especially when discussing vulnerable topics. Why? Because the AI didn't rush them. It maintained eye contact, it used calibrated tone modulation, and it never let awkwardness interrupt the flow of conversation. Another study by USC's Institute for Creative Technologies found that combat veterans were significantly more open discussing PTSD symptoms with virtual agents than human providers. That's not a minor finding. It's a sign that the perceived safety of talking to a machine can unlock emotional honesty in ways that even trained clinicians may struggle with. So, when we ask whether AI communication feels real, we must also ask, real to whom? Because if the patient feels supported, then perhaps that's enough. We need to stop thinking of empathy as a uniquely human trait. Empathy is also about behavioral cues, and those can be engineered, tested, and delivered with consistency far beyond what even a good doctor might manage on a difficult day.
Thank you. Dr. Carter, your thoughts on this engineered empathy? Do patients really feel understood by AI?
It's a fascinating point, and I appreciate the evidence Lina brings forward, but I believe we're missing something deeper. Empathy isn't just about what you say. It's about who you are when you say it. Patients are deeply attuned to presence. They don't just register facial expressions, they read silence. They notice when you shift in your seat, when your voice quivers, when your eyes well up but you don't turn away. A machine, no matter how advanced, cannot replicate that vulnerability. The studies mentioned often involve simulation labs, controlled vignettes, and first-time encounters. But let's ask, what happens when that patient has known their doctor for 8 years? When they trusted them to guide their care, and now that guidance ends with a chatbot? Would they feel clarity? Maybe, but would they feel held? I don't think so. In therapeutic communication, we don't just model warmth. We become a container for someone else's grief. That process changes the patient, and it changes us too. You can't program transformation.
Both of you have pointed to different aspects of communication: clarity, emotional safety, and authenticity. I want to press further into one of Lina's points. If AI can deliver bad news without faltering, is that actually a strength? Dr. Zhang, what do you say to critics who argue that stoic emotional neutrality, the very consistency AI offers, could actually feel cold or detached to the patient?
I hear that concern, but let's remember, many clinicians also appear emotionally flat when delivering bad news, not because they don't care, but because they've been conditioned to hide their own emotion. And sometimes that detachment can feel confusing or even dismissing to patients. An avatar doesn't have that problem. It can express warmth, concern, and validation in a way that's clear, structured, and patient-centric, without the personal distress that can derail a difficult conversation. In fact, patient focus groups from a 2022 pilot at Cedars-Sinai showed that when given a choice between receiving news from a rushed, emotionally avoidant human versus a steady, emotionally attuned avatar. Several patients chose the avatar. So it's not about replacing humanity, it's about elevating communication consistency, especially for patients who've experienced dismissiveness or rushed delivery in the past.
Dr. Carter, your response?
I don't doubt that avatars can be well scripted, but scripts are not relationships, and that's what's missing. There's a reason we train doctors in silence, in breath, in holding the pause. These are not inefficiencies, they're tools of presence. A patient may not remember what we said, but they will never forget how we made them feel in the hardest moment of their life. Let me ask, what happens when a patient breaks down, cries uncontrollably, sits frozen in shock? Will the avatar pause? Will it offer silence rather than move to the next line of the script? You cannot standardize suffering, and any attempt to do so risks reducing the soul of care to software performance.
Let's end this round with one final question to both of you. If you were the patient, facing a life-altering diagnosis, would you accept hearing it from a well-designed AI avatar?
Yes, if it was well executed, emotionally responsive, and came with an option for follow-up with a human clinician. I'd value the clarity, the lack of hesitation, and the ability to absorb the information before engaging with a doctor.
No. In that moment, I would want another person there, not just to speak, but to sit with me. Even if they fumbled, even if they cried with me, because being seen matters more than being scripted.
Two profoundly different answers to a deeply human question, one rooted in the power of precision, the other in the power of presence. Up next, we explore what all of this means for clinicians, the ones who bear the weight of delivering devastating news, often over and over again. Can AI support them, or is it taking away something essential to the healing profession? Welcome back. In this round, we're turning our attention to clinicians and the toll that breaking bad news can take on the people delivering it. Whether it's informing a family of a child's prognosis or telling a patient their cancer is no longer curable, these moments take a toll. And unlike other procedures in medicine, there's no sedation, no gloves, just words, and the weight behind them. So here's the central question. Could emotionally intelligent AI avatars help reduce the emotional burden on clinicians? Or does offloading that task erode the moral foundation of what it means to be a healer? Dr. Zhang, let's start with you.
Thank you. I want to begin with a story, not mine, but from a young oncology fellow I mentored during a trial implementation of a digital patient communication platform. She told me, "It's not the chemo that wears me down, it's the faces. The moments where I have to tell someone their scan lit up like a Christmas tree and then walk into the next room with a smile for someone else. This is the emotional labor of medicine, and it's real. Repeated exposure to high emotion encounters without support leads to empathy fatigue, depersonalization, and ultimately burnout." The 2023 Medscape Burnout Report showed that over 55% of oncologists and palliative care specialists reported significant emotional exhaustion. A major factor, the cumulative emotional toll of breaking bad news. AI avatars offer an opportunity to share that burden, not remove it, but share it. They can act as a buffer, allowing clinicians to preserve their emotional bandwidth without compromising communication quality. We're not saying clinicians should walk away. We're saying, let the avatar open the conversation, establish the facts gently and clearly, and allow the clinician to follow with presence and care, without having to force the first words. It's not detachment, it's supported compassion.
Thank you. Dr. Carter, what do you say to the idea that sharing this responsibility might protect clinicians and improve long-term care?
It's a beautiful idea, and it comes from a place of care. But I believe we're in danger of mistaking emotional discomfort for moral distress, and they are not the same. Moral distress arises when we're asked to do something we know is wrong, but delivering bad news is not wrong. It's part of what we owe our patients. I understand burnout. I've cried in stairwells. I've dissociated mid-consult and had to ground myself. But what pulled me through wasn't escape. It was being seen. By a patient. By a colleague. By myself. When we offload hard conversations to machines, we also risk unlearning one of medicine's core virtues: courage, not stoicism, not numbness, courage, the courage to sit with suffering and not look away. Instead of outsourcing these moments, we should be building resilient systems around clinicians. Peer debriefs, reflective spaces, narrative medicine, time to process. Not handing the task to an avatar and saying, "You do it, I'll be in later." Because over time, what we offload, we begin to avoid. And what we avoid, we eventually forget how to do.
Let's explore a compromise. Could avatars be used not to deliver the full message, but to support clinicians in preparation or follow-up? Dr. Zhang, is there a role for hybrid models, where AI acts as a scaffold for difficult communication, but the human still leads?
Absolutely, and in fact, I think hybrid models are the most ethically sound and emotionally sustainable option. Imagine this: an AI system conducts an emotionally sensitive pre-brief with a patient, gently explains the diagnostic context, sets expectations, answers logistical questions. The human clinician then enters with the final decision or message, but the emotional groundwork has been laid. This frees up emotional bandwidth. It also creates space for the doctor to focus on presence, not performance. Similarly, post-disclosure AI companions can help the patient process, ask clarifying questions, and deliver supportive information in structured, calm language that clinicians may struggle to offer when they're overwhelmed. The AI is not the hero, it's the steady, quiet assistant who holds space until the human arrives.
Dr. Carter, do you see any ethical space for this kind of hybrid handoff?
I think it depends on intention and transparency. If patients know they're speaking to an AI, if the tool is clearly framed as preparation, not replacement, and if the clinician remains fully engaged, then yes, it can be a helpful adjunct. But here's the risk: it becomes a crutch. Clinicians start relying on it too much. They start to lose comfort with their own emotional responses, and that's dangerous. Because being uncomfortable isn't failure, it's evidence that we still care. So yes to hybrid use, but only if we preserve the clinician's primary role in delivering the core message, in person, fully present.
Let me pose one last question for this round to both of you. Is it more ethical to preserve clinicians' well-being by sharing this task, or to preserve patients' dignity by ensuring a human is always present at the point of impact? I believe we can do both. If the system is designed with compassion, clarity, and ethical safeguards, AI can support clinicians and protect patients. Dignity is about feeling respected and informed, not necessarily about who delivers the words.
I believe dignity comes from being met, eye to eye, heart to heart. There are some things we should not share with machines. Pain deserves presence. Suffering deserves witness. And that witness should always be human.
Two deeply thoughtful reflections, one looking to ease the burden of care through technology, the other committed to holding that burden as part of our human contract. Coming up, we explore trust, consent, and the ethics of delegation. If a patient receives bad news from an AI, who is responsible? And can trust survive automation? We now arrive at what may be the deepest layer of this debate: trust. Can patients truly trust an AI avatar delivering bad news, even if it's technically competent and emotionally responsive? If an AI agent communicates a life-changing diagnosis, does that redefine informed consent? Does it undermine the therapeutic relationship? And crucially, who is responsible if the conversation goes wrong? Let's begin with Dr. Carter. What concerns you most about trust in AI-mediated conversations?
Everything in medicine flows from trust. Not just trust in the diagnosis, but in the person delivering it. When a patient hears devastating news, they're not just processing facts, they're anchoring themselves in the emotional posture of the person across from them. That's why traditionally we don't delegate these moments to junior doctors, nurses, or administrators. We give that responsibility to the lead clinician, the one the patient has been building rapport with over weeks, months, or even years. To replace that moment with an avatar, no matter how well designed, is to tell the patient, "This moment is less sacred than it used to be. You're not worth the weight of human discomfort." And what about consent? Did the patient agree to hear devastating news from a machine? Were they told that they could choose otherwise? Transparency is essential. Without it, we risk crossing ethical lines that damage long-term trust, not just in technology, but in the entire health system.
Dr. Zhang, how do you respond to the argument that patients may feel abandoned or that trust is eroded when an avatar becomes the messenger?
It's a powerful argument, and I absolutely agree with Emily on one key point. Trust must be earned, not assumed. But trust isn't only built on presence, it's also built on clarity, predictability, and emotional safety. If an AI avatar can deliver news calmly, clearly, and with validated emotional models, it can actually feel more trustworthy than a clinician who stumbles, avoids eye contact, or softens the message so much that the patient leaves confused. We also have precedent. Patients already receive serious news through intermediaries. Think of radiology portals, pathology reports, nurses conveying critical updates. The idea that only one human has the moral right to deliver news doesn't reflect the reality of team-based medicine. Where I strongly agree is on transparency. Every patient should know you are about to hear important information from an AI agent. You may choose to continue with a human clinician instead. This isn't about deception, it's about augmentation, supporting clinicians with tools, not replacing them without consent.
Let's take this further. Suppose a patient becomes distraught after hearing bad news from an avatar and claims no one explained it would happen that way. Is the physician liable? Who owns that moment ethically and legally?
The physician, always. We cannot offload ethical responsibility to an algorithm. The patient is under our care, not under the avatar's care. So if a patient leaves the room traumatized or confused, the clinician, and by extension the institution, bears responsibility. That's why this technology cannot be deployed without strict governance, documentation, audit trails, and opt-in protocols. Otherwise, we risk eroding the foundation of accountability in clinical care.
I agree completely. Governance is key. But I'll also add this. When deployed with proper consent and oversight, avatars may actually reduce the risk of communication failures that lead to litigation. Why? Because they follow validated scripts, avoid ambiguous language, and deliver information consistently, all of which are protective against misinterpretation. I envision a future where the avatar transcript becomes part of the medical record, a documented, time-stamped, emotionally intelligent conversation that complements the doctor's own notes. So it's not about dodging responsibility, it's about using tech-assisted communication to make ethical care more precise and potentially even more defensible.
Let's zoom in on something critical: the therapeutic relationship itself. Does outsourcing the delivery of bad news weaken that relationship? Or can it be strengthened through delegation? Much like how nurse practitioners, social workers, or allied health staff contribute to trust over time?
The therapeutic relationship is fundamentally human. It's not transactional, it's relational. It deepens over time and is marked by presence, memory, and mutual recognition. If the patient hears their diagnosis from a virtual avatar, even with prior consent, we risk interrupting the emotional arc of care. Suddenly, the continuity breaks. It becomes, wait, was I not important enough for my doctor to say it themselves? That may not be what the system intended, but it's what many patients will feel.
I'd argue the opposite is possible too. When used skillfully, avatars can enhance trust by preparing patients thoughtfully so that when the human clinician enters, the conversation is deeper, not shallower. And in populations with medical mistrust, such as those with a history of systemic bias, AI agents have been shown to reduce perceived judgment, leading to more open dialogue. So, yes, the therapeutic relationship is human, but it can be supported by technology that expands access, protects emotional safety, and removes unintentional harm.
Let's close this round with one final question. If trust is sacred in medicine, is it ever ethical to let a machine hold part of it?
Yes, if the machine is transparent, well designed, and supervised. Trust isn't about the medium, it's about how care is experienced. If the patient feels seen, safe, and informed, that is trust.
No, trust is about presence. It's about knowing that in your darkest hour, another human chose to face it with you, not to send a stand-in. That's not old-fashioned, it's human nature.
Two voices. One sees tech as a guardian of clarity, the other as a guardian of humanity. Coming up next, the lightning round. Rapid-fire rebuttals, surprising statistics, and unfiltered takes from both sides. It's time for the lightning round. 7 minutes, 7 provocations, and no holding back. Dr. Zhang, Dr. Carter, I'll throw you each rapid questions. 1 minute or less per response. Punchy, personal, persuasive. Ready? Round 1. What scares you most about the other side's argument?
That we normalize detachment, that we get so used to avatars doing the hard stuff, we forget what it feels like to be vulnerable, present, and human in medicine.
That we romanticize suffering, that we demand clinicians absorb endless emotional pain when technology could help and call that compassion.
Round 2. One statistic that proves your point?
In a 2021 pilot study at Mount Sinai, oncology patients rated avatar-delivered results as equally empathetic and more clearly explained than those given by junior physicians. Consistency matters.
A 2022 survey by the AMA found that 87% of patients want bad news from a trusted human provider. Not a screen, not a script. That's not nostalgia. That's instinct.
Round 3. Who gets to decide, the system or the patient?
Always the patient, but only if we're honest about what we're offering. Don't call it support if it's a handoff.
Also the patient, but give them options. Some would rather hear difficult news alone, gently, with the ability to pause, reflect, rewind.
Round 4. What role do emotions play in communication?
Huge role, but not all emotions are helpful. Some cloud, some clarify. Avatars can model calm, measured, compassionate affect without fear, panic, or projection.
Emotion is the bridge between fact and meaning. It's not an obstacle, it's the point. The patient doesn't just want the what, they need someone to sit with the why.
Round 5. Would you want an avatar to break bad news to you?
Absolutely not. If I'm dying, I want a face, not a firmware update.
Yes, if I knew the avatar was trained, unbiased, emotionally attuned, and gave me space to absorb before seeing my doctor, especially if I needed time to cry alone first.
Round 6. The slipperiest slope?
Using humanity as an excuse to maintain outdated, uneven standards of communication. We've all seen terrible consults by tired doctors, let's be real.
The illusion that a well-scripted interaction is the same as care. It's not. Communication is more than words. It's relationship, and that can't be coded.
Round 7. One sentence to win over the skeptics?
Bad news needs not just clarity, but courage, and only humans can offer that in its full form.
When thoughtfully deployed, AI avatars aren't replacing empathy. They're preserving it by supporting the humans who deliver it.
A rapid-fire round that reminds us, this isn't just about machines, it's about meaning. Final statements are next. 2 minutes each. No interruptions. The last chance to sway the audience before the vote. It's time for final statements. Each of our debaters has 3.5 minutes to share one final reflection, free of interruption, free of rebuttal. First, Dr. Lina Zhang.
Thank you, Dr. Park. Let me begin with a story of a patient who sat in a sterile room waiting to hear the results of a biopsy. Her doctor was late. The nurse was tense. When the news finally came, it was blunt, cold, and rushed. Not because the doctor didn't care, but because he was exhausted, behind schedule, emotionally stretched. That patient told me she wished she could have heard the news more clearly, more gently, and with time to process before everyone started talking treatment. That patient was my mother. So when I speak about AI avatars delivering difficult news, it's not from some cold tech evangelist corner. It's from someone who knows how hard this work is and how often clinicians don't get it right, not because they don't want to, but because the system makes it nearly impossible. Emotionally intelligent avatars are not science fiction. They exist. They're tested. They've shown real promise in simulations and early clinical environments. And no, this isn't about removing doctors. It's about giving them backup. Imagine a calm, soft-voiced avatar gently explains the initial diagnosis while the patient sits in privacy. They can pause, they can rewind, they can breathe. Then the doctor comes in, not to break the news, but to walk with them through the next steps. That's not robotic care, that's compassionate design. If we wait for the perfect moment, the perfect clinician, the perfect setting, millions will continue to receive life-changing news in environments that are rushed, emotionally jarring, and ethically inadequate. We owe patients better, and we owe ourselves support. This is not about machines replacing humanity. It's about machines helping us show up more human, more present, and more prepared.
Thank you, Dr. Zhang. Now, Dr. Emily Carter.
Thank you. There's something we've lost in this debate, not through oversight, but by design. It's the unmeasurable, the trembling silence before a diagnosis is spoken, the hand held when there are no more options, the tear that falls from the doctor's own eye as they sit with someone whose life just changed forever. You can't code that. You can't replicate that. Yes, AI avatars are improving. Yes, they can deliver information with clarity, even a simulation of warmth. But let's be honest, we're not just delivering news, we're delivering witnessing. We are standing beside a person at their most vulnerable. We are honoring that moment not with polish, but with presence. And presence means being fully there, flawed, human, real. AI might get the words right, but it doesn't grieve with the patient. It doesn't take on the weight of the moment. And that weight, painful as it is part of what binds patient to provider. When we remove that from our practice, we risk practicing at a distance. And distance, even when well-designed, is not intimacy. I'm not anti-technology. I use AI in my clinic. I believe in support tools. But when it comes to delivering a terminal diagnosis, a miscarriage, the end of a treatment line, that's not a space for interface. That's a space for intimacy, vulnerability, and shared humanity. Let's build tools that help us prepare, tools that help us recover. But let's not surrender the sacred moment at the heart of medicine. Because long after the data is forgotten, the patient will remember the eyes that met theirs, the voice that didn't flinch, the human who didn't look away.
Two voices, two visions. One challenge. How do we care with both compassion and courage in an age of accelerating technology? The choice, as always, belongs to the future and to you. Coming up, the audience vote, reactions from our medical panel, and closing reflections. And here we are, at the closing moments of today's debate. Whether you came in skeptical or optimistic, certain or undecided, you've now heard two powerful visions for the future of one of medicine's most sacred acts. Before we go to the vote, let's hear from our special guest panel, two practicing clinicians who spend much of their time navigating the hardest conversations in medicine.
As someone who's delivered hundreds of bad news conversations, I felt both sides spoke to real truths. Dr. Zhang is right. Sometimes I'm not my best self in those moments. I'm tired, I'm rushed. I wish I had a supportive AI interface that could help me prepare patients with dignity and clarity. But I also agree with Dr. Carter. When I've had those deeply human moments with my patients, they remember me, not the scans or the words. They remember how I said it. That emotional imprint shapes everything that follows. Maybe the future is not AI instead of humans, but AI next to humans, so we don't have to choose between efficiency and empathy.
I echo that. In my field, the breaking of bad news isn't just a moment. It's a relationship milestone. Patients don't just want information, they want containment, a holding space. That said, I've seen cases where AI-generated voiceovers helped immigrant families better understand prognosis in their native language. It gave them space. It's not always about immediacy. It's about accessibility and control. So I'd say use AI ethically, transparently, and never as a shortcut. Use it when it helps humans be more present, not more absent.
Thank you, Dr. Torres and Dr. Mehta. Thoughtful, grounded, and resonant. Now, let's turn to you, our audience. As always, we took a poll before the debate began. At the start of today's episode, 32% of you believed AI avatars could deliver bad news better than human doctors. Now, after hearing both sides, the number has shifted to 44%. That's a gain of 12 percentage points for Dr. Zhang's side, but the majority still holds with Dr. Carter. Debate result: Dr. Emily Carter wins today's round, but the gap is closing. Today's debate wasn't about machines replacing humans. It was about whether machines can supplement us in moments that matter, and whether we're ready to trust them with the emotional weight of care. As AI becomes more integrated into healthcare, these conversations won't just happen on podcasts. They'll happen in hospitals, in policy rooms, and at bedsides. And maybe, just maybe, what we really need isn't to choose a side. Maybe what we need is to build systems that honor both precision and presence. On the next episode of Humans vs. Machines, we'll tackle a hot-button issue. Should AI decide who gets an ICU bed? Rationing, fairness, and the role of algorithms in life and death triage. I'm Dr. Emily Park. Thanks for joining us. Until next time, stay curious, stay compassionate, and don't be afraid to challenge the machine.